Executive Plastic Surgery. Welcome to another YouTube, Instagram, Facebook, and TikTok Live. It's a pleasure for me to be on. So we will go ahead and start talking shortly, but I want to go ahead and thank Ahmad, who has been integral in setting up this studio so that I can go ahead and start doing this hopefully on a daily basis. So please feel free to ask any questions, and I'm going to do my absolute very best so I can help you understand how I look and basically manage the many patients with breast implant illness and what are the challenges as I assess each and every patient. Now, as you will see, there's so many different patients that come from literally all different walks of life, from all the different states. Just right now, I finished a case from a nice lady from Boston, Massachusetts. Earlier, another patient, she had come to me, local patient. And so the patient I'm going to see next is from California. At the end of the day, the patients may have a rupture, contracture, they have a mass or fluid, as you have seen. But at the end, this is what we as plastic surgeons need to do: is we basically standardize and establish what are the goals of the surgery. And this is where, so there is no kind of budging from this concept, at least in my practice, and this has been consistently the case. So what is what I call the CON procedure, which is basically from one patient to the next. This is how I have done all my patients consistently, so that there is a standardization and that absolute commitment to removal of the capsule. So the first thing is, I have not used no drains. I have not used drains in any of my patients, the GP drains or the other types of drains that exist, where they are placed into the chest cavity, because all of that inflamed tissue is removed. There is no spillage of the silicone. No capsule is cauterized because all of the capsule is removed. And now there is no burden left behind that's going to induce fluid or seroma formation. And as you will see, my patients do not go to another center afterwards and get drains because they did not need them to begin with. And they all, just like any plastic surgery procedure, be it a tummy tuck, thigh lift, arm lift, gynecomastia, the patients need their pressure garments, in this case, the bra and the binder. And so this has been consistently the case. The blood loss is less than 5 cc's, hence the need for the drains is not there. The second thing is, majority of the patients, well over 80%, do not need that unnecessary lift. The many patients in their 50s and 60s that I've managed, when they have had a good surgeon, relatively speaking, small implants, recoil of the skin, recoil of the breast tissue as well, with the fluffing effect now that the implant is not there, with the gravitational pull of the breast tissue down, with the implant gone. Implant pulls, gravitates the breast tissue down. With that gone, the tissue recoils. The inflammation that subsides, now it recoils better. So if you have someone with a mosquito bite, if you will, the face and the eye will tend to droop. But when the inflammation subsides, you will see that skin goes back to normal. And so with the inflammation subsiding, you will see the skin is going to recoil and the breast tissue is also going to recoil. With the 5, 10, 15, 20% muscle mass you're going to add to your chest, and with the excess skin that I removed and the internal sutures that I placed, which is the Con Pseudolift, the Con Dakai Pseudolift, the need for the lift in majority of the patients is not there. The third thing is, I always return the implants to the patient. So that the patients know exactly what was inside their body. Last week, there was a patient I removed silicone implant, and she could have sworn, and she always knew she had saline implants, and she had what were the textured silicone implants. Another patient had one implant, Allergan, another one was Mentor. So it's important to return the implants and to show that the implants were not damaged on the way out. Number 4, I send the capsules off to pathology, where the capsules are in its entirety removed, such that that in itself is the proof. If you look at the dimensions on the pathology report, you will see if it's like a 400 cc implant, the dimensions are approximately 12 by 12 centimeters by the thickness being maybe 1 centimeter by 7 centimeters. So you will see, and actually that will be the ultimate proof that the capsule was indeed removed in the manner as described and not partially. I saw a pathology report where the capsules were sent and it was a small piece and clearly shows that the entire capsule was not removed. Cauterizing a capsule is not as good as removing it. It has to physically be removed from the body. And this is how I do it, so that this is the ultimate goal of the surgery. And the pathology must be done to the representative samples of that capsule, so that when the pathologist looks at the sample, he or she knows how to get the specific and the biopsies from representative areas. I heard of another surgeon who was just sending a small part of the capsule after pathology, which is wrong. This whole capsule must be sent so that the pathologist, using his discretion and analysis, can then find out the representative areas that he or she can biopsy. So the entirety of the capsule must be sent to pathology to rule out that rare BIALCL, to rule out the squamous cell cancer BIA, which is the breast implant associated, squamous cell cancer, breast implant associated, anaplastic large cell lymphoma, breast cancer, whatever it may be. And then the inflammatory cells, if present within, then we can learn more about what was present inside and what was not. The fifth thing is I take cultures for aerobic, anaerobic, and fungal sent to the microbiology lab, so we know what bacteria, if present, that we can treat accordingly if needed. Fungal cultures are done for bacteria and fungus as well, aerobic, anaerobic bacterial cultures and fungal cultures, so that if the patient does have that infection, that she can then be treated. Number 6, twilight deep sedation. Also on almost all the patients are not paralyzed and the ventilator is not doing the general anesthesia. I do what is propofol, fentanyl, Versed, and the patients overall then benefit from lack of paralysis, no ventilator breathing. They relatively bounce back, and to date, as you will see, not a single patient has woken up from their surgery or have had any recollection of the surgery. And number 6, no matter what, the one patient to the next, and this was the point I made earlier. The last week I took care of a patient. She had an open wound. She had a history of stroke just 3 months ago. She got the same surgery that my young 38-year-old patient got earlier today, and what every patient gets. So there is no compromise in the surgical procedure because of the patient's age or comorbidities, because every patient deserves that world-class first best care. And this is where the Khan procedure is key. And this is where I find that, as you have seen me say this the many times in the Facebook, YouTube lives, that 20 years from now, I cannot imagine the surgery being any different, being done any differently. So the end block is key. So why is that important? If you look at the case from last Thursday, she had saline implants. We do not want to basically potentially have that fluid leak into the chest. We do not want to leave any masses behind. That irregularity, that questionable capsular tissue that might potentially have CD30 positive, like 3 of the patients that I have managed in the last year and a half. We do not want to leave that tissue behind with a big uncertainty if this was even potentially what may be a precursor to the lymphoma. So I'm giving the patient the best shot. And this is essentially boils down to the last and probably the single most important part of this whole procedure is high definition pictures and videos of the chest wall showing complete removal. If there is that one thing, along with each one of those things, especially the capsule being sent to pathology, that authenticates, certifies, basically that confirms and reaffirms and gives no doubt, is where the surgeon takes the high definition videos of the chest wall showing complete removal of the capsule, the surgical approach, and maybe even in some surgical cases, the step-by-step approach. I tend to do that in almost all the patients where the patient has had residual capsules. So I take a video showing as soon as I enter the chest what I saw, as I'm dissecting what I'm dissecting, and as I've completed what I've removed and what remains behind. So 4 videos showing that this is what I encountered, so that the patient has that peace of mind that I did absolutely remove all of that residual capsule in the many cases where the surgery was not done optimally correctly the first time. This is the take home message. You want to do the surgery once, you want to do it definitively, consistently. Number 3, you want to have the entire capsule removed. And number 4, all of that capsule that is removed, not small parts of it, but the entirety of the capsule is then sent to pathology, so that we know what it is and what it is not. And you have the peace of mind that a complete, definitive, comprehensive workup is done. Now, in my case, I want to go ahead and expand on this and say, what are the 5 different ways that kind of reaffirm, certifies, authenticates, and gives you that peace of mind and confidence that your surgeon is doing the right surgery, meaning the explant. Number 1, the high definition videos of the chest wall and pictures of the chest wall showing complete removal of the capsule, because what could be more of a proof than that? Number 2, the length of the incision. So this one nice patient from Boston, she went to a local surgeon and she was told her incisions was just going to be like slightly over an inch or so, not too big. And I will tell you, the diameter of the implant essentially dictates the length of the incision. So if the surgeon's trying to do an end block through a nipple areola complex incision or up and down incision, it is very hard to basically dissect the entirety of that capsule off of the rib. As you will see in the many high definition videos that I have on YouTube Shorts, you will see that the capsule spread is all the way medial to lateral, superior to inferior, anterior, and the entirety of the capsule sits over a relatively large area. And so the horizontal incision only that I have, without touching the breast tissue, I'm able to remove the entirety of the capsule definitively off of the rib, which is the hardest part of the case. The third thing, the length of time. So on average, I take 4 hours to doing the surgery, because that's how long it takes to meticulously dissect off of the rib in and around, such that all of that capsular burden is removed. So if you see your surgeon doing the surgery in an hour and a half or 2, there's a big question mark. I see surgeons doing a supposed end block plus a lift plus fat grafting in 2.5 hours, and I'll tell you that is virtually impossible. I want to see a video if and how that surgery is done, because that is humanly impossible without doing what is a true end block in the manner that I do, as I describe and as I define on my YouTube and my Facebook page, primarily the YouTube Shorts. The YouTube Shorts gives you a chance to see very graphic videos, such that the Facebook is not going to put like a block, or the YouTube, even with not meant for children, you will be able to see very graphic videos, because you want to see exactly what's being done. Number 4, the implants need to be returned to the patient. There are many surgeons who kind of puncture a saline implant, or they try to remove the implant, and you can see the capsular tissue is partially left behind. A patient may have 2 capsules, a primary and a secondary. You want to make sure that when the implant is removed, that the implant is returned to the patient, because that in itself is kind of proof that the surgeon did not damage or hurt the implant on the way out. Truly doesn't apply to silicone implants, but saline implants is basically where and what I'm alluding to. Number 5, the surgeon must not be augmenting. That is supremely important if you ask me. In the time that I took today to do the 2 cases, I could easily have done 6, at least 5 to 6 of these augmentations in a given day. And this tells you, when a surgeon is only explanting and not augmenting, he or she is taking a pay cut by almost 2/3, meaning the surgeon's salary is only a third of what it would be and could be and should be if he were augmenting, meaning you make at least 3 times as much augmenting than in the time that you take the time to explant, because the average explant time is 4 hours, and the average time to augment takes 45 minutes to an hour. And so this is where the surgeon is willfully and deliberately, purposefully not augmenting, because he or she does not believe in implants. Now, this is very important. You have to look at the business, and you have to see within their practice, there are surgeons who say, I'm going to market myself better by only explanting, whereas the surgeon next door is getting all the augmentation. So they're capitalizing on both, because now you're making yourself more marketable by only explanting, and you're selling yourself better to those group of patients who are looking for only explant surgeons. And this is truly the essence and the gist and heart, where the surgeon is actively talking about how he or she is doing it. Ideally, every surgeon must have a Facebook page where all his patients are now exchanging pictures, videos, talking about the experience, how the surgery was done, and that they truly is a check and balance and a transparency. So the surgeon is allowing for his previous patients to, or her previous patients to talk and discuss. And that truly is, if you ask me, a check and balance. Plus what the surgeon is saying, plus the surgeon is not augmenting, or neither is the business benefiting by having a co-surgeon who's taking all the augmentation cases, and the surgeon, him or herself, not augmenting and claiming to be an explant. And deep down within, I've heard this directly from the surgeons. They certainly do not want to believe in breast implant illness, but this is another aspect of their practice that they're trying to add on. So you want to be very careful. I have stated this: if you truly want to check, you tell the surgeon what would you do next, and the majority of the surgeons would say replace, and deep down within that this is not what your surgeon will has breast implant illness as a top priority. And I remember, it's not only about the breast implant illness, but appropriately working up, assuming that all the implants are ruptured till proven otherwise, that all the implants have some fluid around them or masses around them, and that every case is done in a very thoughtful, systematic, purposeful, deliberate manner. So there's a whole intent of removing the whole capsule sincerely as the surgeon is going into the surgery. If you ask me, this whole surgery is dependent on the surgeon's personality, how meticulous, how honest, how respectful he is to the whole explant process, how much time and commitment. And it must and should show, as you talk to the surgeon directly, that he truly cares into removing the whole capsule. Anyone can remove implants, and it's all about the capsule. You will see many surgeons, unfortunately, have hired a lot of liaisons who are doing all the talking. I can tell you, you don't need to hear the liaison. You need to talk to the surgeon directly. You need to interview the surgeon directly. You need to not be talking to the medical assistant, the PA, the nurse practitioner, medical assistant, or the receptionist, or the office manager. You need to talk directly to the surgeon and directly have a full conversation. And you need to have that legal bind on that consent form, where you must demand pictures must be high definition, videos will be made so you can see clearly, so that there's a check and balance on me and certainly on all the other patients. And this is that informed consent you have. So as you go into the surgery, there is no surprises. There is that peace of mind that your surgeon is a firm believer, and that he or she shows exactly how the surgery is done. So hopefully you found this informative. Please ask questions, and I'll be more than happy to answer. Please go to the YouTube Live, YouTube Shorts, YouTube videos, and you will get a lot of these questions answered one by one. And if you have any questions, I plan on doing another session where I will be able to answer those questions. I will also excited to announce that we are going to do another session like this with our anesthesiologist, MDA, Dr. Alex Lamar. So he will be available in the next few weeks, so that he and I will sit down and we will take any questions from anyone who is interested in having our anesthesiologist answer any questions pertaining to the surgery and the anesthesia aspect of what is explant surgery. So there you have it. This is Dr. Khan, Executive Plastic Surgery.